And Dr. Greenspun, hi Harry, is the Chief Medical Officer, hi Doctor, and Managing Director of Korn, Ferry Solutions. He's the co-author of Re-Engineering Healthcare, a manifesto for radically rethinking healthcare delivery. And he's been recognized as one of the 50 most influential physician executives in healthcare by Modern Healthcare. So please join me in welcoming Dr. Harry Greenspun.
Well, it's great to be closing out this, what's been a fantastic program. I'm biased. I think Carrie's session was actually the best of all of them. But for many of you know that besides being married, we live in Washington, D.C. So taking a play from Sean Spicer's playbook, I just want to say that it has been widely reported in the media, including the New York Times, that a body fat monitoring scale is an outstanding gift for someone. So. Anyway, just so you understand my background, so I'm a cardiac anesthesiologist, started at Hopkins. I got involved in health IT way back when we were tracking patients with paper forms, doing minimally invasive heart surgery, and got involved in using database-backed websites to track them. And getting that off the ground, I wound up as the Chief Medical Officer at Dell, and I spent the last 6 years at Deloitte leading their Center for Health Solutions. And I find myself now at Korn Ferry Health Solutions, working on more of the people aspects. Excuse me. You know, throughout the day, we've had really excellent conversations about, you know, how can we improve healthcare and what's going on. And what I want to talk about, I want to build on some of Summer's comments as well, is why this is kind of challenging. And I'm not going to be like cold water, but I want you to understand some of the nuance of why this is challenging. Because when we think about, you know, the future of healthcare, really the future of healthcare is the present day of every other industry, right? And why is that? Why has it taken us so long to sort of catch up and sort of learn the lessons of these other industries? And there are a bunch of things we're talking about. There are sort of three kind of pervasive things which I'll run through. One is what Summer mentioned, really about our payment system, you know, moving from fee-for-service to value-based care. Why is that important? I'll give you a great example, and we'll talk about telehealth. Now, telehealth is awesome, yes? How long has telehealth been around? Hazard a guess, just yell it out. We've got 20 years over here. Anybody else? Would like The Price is Right? It's been around 100 years, right? When the phone was invented, someone goes, wow, awesome idea. We got someone sick over here with pleurisy or whatever the hell they had 100 years ago. And we've got a doctor / barber person over here. We can do remote medicine. It sounds awesome, right? It's been around for that long. It hasn't caught on, not for a lack of good technology. It's been a lack of aligned incentives around payment, right? Because if you are an organization that, so for example, Kaiser Permanente adopted just secure messaging for telehealth. Ages ago, they developed secure messaging. You could send them an email to your doctor to get a response back. And they were able to drop their in-person visits by about 20%, right? Now, if you're Kaiser, that's awesome, right? But if you're Northwell, right? If your volume drops by 20%, that is a disaster, right? People get fired for stuff like that, right? And so it's only when it makes economic sense that we get adoption. That's why you're seeing now with more of these provider-sponsored plans, now you see a rapid adoption of telehealth. You see a lot of embracing of these sort of technologies because suddenly it makes economic sense. So that's a key thing. That's going to run through a lot of my comments. The second thing is the way we perceive healthcare is not necessarily the way people in healthcare perceive healthcare or consumers perceive healthcare. And again, I use the term consumers because people are really only patients when they're in front of a provider. The rest of the time they're out, you know, going to the grocery store, or going snowboarding or bungee jumping, whatever the hell people do, right? They're making decisions about their healthcare. And so they're only a patient when they're with a provider. But one of the fascinating things is that people's view of healthcare is not necessarily how healthcare views it. Easy question. Is United a good airline? It really depends, right? It depends on a lot of stuff, right? And for most of you, if I asked this question last week, what would most of you have said? Someone would say no, and some would say, yeah, United is awesome. right? And the reason you'd say that is based on what? A thorough analysis of United's on-time track record, of their bag policy, this and that, their various fees, their route. What would it be based on? It would be based on the last time you flew on United, right? Think of all the people who loved Delta a week ago, right? They hate Delta now. Or people who've flown another airline for ages, they lose their bag once, boom, they hate that airline. The airline is terrible. And so when you survey consumers, the consumer's view of healthcare, they have very, very strong opinions about, if you ask them, does the United States have a good healthcare system? They have very, very strong opinions about it. But they are almost entirely based on the last time they went to the doctor. Okay? And this is a big challenge that we have. And we talk about, should we adopt, the Canadian system, the UK system? It's very hard for people to understand, for the average consumer to understand what it would be to adopt someone else's healthcare system. They don't even understand our healthcare system. I don't even understand our healthcare system. If you gave someone who's very learned a big whiteboard and said, draw out how our healthcare systems work, they couldn't do it, right? Couldn't do it. And so our ability to understand what's going on in healthcare, it's incomprehensible. So when you ask, hey, do we have a good healthcare system? You say, well, last time not so bad, or last time was awful, terrible, right? That's how people make decisions. The other thing is that even employers, right, who pay for most of healthcare, don't necessarily pay for healthcare, right? How many of you have a wellness program as part of your benefits, right? So what's your name?
Ralph.
Ralph. What do you do in your wellness program?
So we have reimbursement for things like belonging to an athletic club,
right?
Equipment, or things like that.
Fantastic. So you get money to do stuff. Now you look pretty fit.
Thanks.
Yeah. Your company gives you money to do stuff you probably already would do, right? Did you belong to a health club beforehand?
Yes.
Yeah. Did you buy fancy shoes before that?
Not so much.
Not so much, but you got a little fancier shoes. Yeah, you have something fancy on? What do you got? What do you have?
Apple Watch.
An Apple Watch? Okay. Okay. Do you track your exercise, right? Do you like exercising?
Yeah.
No, you don't. No one likes exercising, right? But I imagine you're comparing with other people. That makes a lot of sense, right? So the fitness industry figured that out, right? The fitness industry got you to do something you don't want to do, right? You even have satellites from space monitoring your exercise, right? Your GPS enabled, right? So again, so your company, right, is doing a wellness program, right? But it's interesting when you look at corporate wellness. There are really three reasons people do, I'm doing my slides here for you, right? Three reasons people do corporate wellness. One is to make Ralph healthier, right? But Ralph's pretty healthy, right? Don't need to do that, right? Other thing they do is they want to lower their healthcare expenditures, right? That's another reason people do that. Do you think it's lowering the healthcare costs of your organization?
Probably not so much.
Probably not so much. But do you feel better about them? Are you more likely to stay? Yeah, here we go. We hit it, right? We hit a nail on the head, right? So for many places, their wellness programs have nothing to do with wellness. They're just about employee retention, right? That when someone, these millennials who you can't satisfy for anything, right? Then when they apply for a job, they go, hey, someone better pay for my yoga pants, right? And so the behavior we see, the health behavior we see, whether it's the government or employees or others, is not necessarily related to health. Okay? We like to dress it up that way, put a red cross on it, make it healthy, right? But it's often not related to health. So these are things sort of like are pervasive across why sort of healthcare hasn't moved around, and I'll touch on these sort of repeatedly. But keep that in the back of your mind, right? Is this really a health thing? Nah, right? Is it really, are these patients or individuals thinking about, is this really something that's important to me? Not necessarily, right? And are we going to pay for it in a way that makes sense? The other challenge really around the payment issue is, of course, value-based care is really cool, but it's very sporadic, right, in its distribution. So you go to Denver. Anyone from Colorado? Any Colorado folks? Of course, everybody. Wow, look at that. Right? It's like overrun with ACOs, right? Loads on, when you look at some of the original people participating in ACOs, lots of accountable care going on in Colorado. Must be having something to do with the weed out there. That I guess it's like, hey, we got to figure out how to make everyone healthy here. Versus you go to San Diego, right? Very little happening in value-based care. Right? They're going to ride fee-for-service until that horse dies. Right? Similarly, Cleveland Clinic, right? These places, these bastions of incredible health care, are really based on how do they actually do incredible procedures and incredible treatments on people who are sick. They're focused on that kind of thing. And if you sort of peel back the onion, that's really about bread and butter fee-for-service healthcare, right? So some of the most advanced places on earth are doing absolutely straightforward fee-for-service stuff. Now, a place like Geisinger, right, which Summer mentioned, right? You've got these closed systems, you integrated delivery systems, Kaiser, Geisinger, others. And they're awesome, but very often they're in isolated kind of areas. Intermountain as well. Intermountain's a great place. It's sort of, have anyone been to Salt Lake City? Right? It's like nothing else out there. That's it. And Mayo's even worse, right? I mean, there's nothing else out there. And you try to bring these models into a highly competitive quasi-fee-for-service, quasi-value kind of market. Very difficult for those folks to do. Mayo opened a place in Florida, having a lot of trouble out there. Not that doing value-based care, but just different models of healthcare entering a different geography don't do so well. So these are all the kind of things to think about. The bigger challenge is as we move toward this new future of healthcare, is it's making healthcare do stuff that we really don't know how to do. And Summer touched on a bunch. I want to sort of delve into a few of them as well. The first one is about sharing information, right? Why do we not share information now?
Share information all the time. Yeah.
Why does healthcare not share information? Yeah. So again, we're contrasting future healthcare, present day of other industry. I mean, side note, so our kids are on the big bus right now, right? Carrie and I are great at, like, we'll go to a conference, we'll put the kids on a bus somewhere in this country, and usually they come back. But we know where they are. We can track their they're not emotions. We can track their positions, right? We can track what they're spending money on, right? We can track all sorts of, even our dog. Our dog has a GPS tracker on his collar. And an activity, we know he's getting walked. We know he's getting an amount of exercise, know exactly where he is, right? That kind of information sharing is easy, right? Why don't we share information in healthcare? Why don't doctors share information with other doctors? It doesn't even appear that you're getting way too doctory.
They don't want to be in camp. Fear of liability.
You're getting too lawyery over there. We got all the. I'll make it super easy. It's bad business. It is bad for business to share information. That sounds bad, right? But what it is the reason most people go to their doctor is their doctor knows a lot of stuff about them. And the ability to shift from one doctor to another historically has been really, really hard, particularly if you have a lot of medical problems, right? If you have a lot of medical problems, you have a really thick chart, right? And presumably if you have a thick chart, it's because your doctor knows a lot of stuff about you and someone else won't know that kind of stuff. If it were easy to move around from doctor to doctor, people would do it, right? People don't, right? Because their doctor knows a lot of stuff about them. It's actually interesting, not until the office staff pisses them off do they think about switching, okay? And it's a really interesting thing because all of us know people who continue to see a terrible doctor and have terrible outcomes, right? And it's not until actually they're upset by how they were treated that they wind up going somewhere else. And this is why when you survey consumers and you ask them, do you have a good doctor? Let's do it right here. Who's got a good doctor? What's your name? George, how do you know?
I like him.
You like him?
He's a military doctor.
Military doctor?
See him in the gym, my gym.
Okay, he hangs out in your gym?
He's in good shape.
Okay, he's in good shape? Okay. Interestingly, all right, I didn't hear a lot of quality issues in those kind of things. What I heard actually, and what most people respond with is, well, you said I like my doctor, right? I like my doctor listens to me, I get an appointment. What most people are is service, what it's like to go to the doctor, right? Going back to our United discussion. And so when you ask people about the quality of care they get, what they respond with is much more about service and what the interaction is like. And it's never about quality. It's never about, based on my age and family history, I have all the necessary preventive care I'm supposed to get. No one says that I had the same knee operation as this other person. I'm back to running 3 months earlier than the average person. Nobody says that, right? And so the way we evaluate our physicians, the way we evaluate the quality of care is based upon the service experience that we get. So Carrie and I were driving up with the kids from DC, come over the Delaware Memorial Bridge, and there are billboards on the other side on the Pennsylvania side, right? Which are the traditional healthcare. There's a traditional healthcare billboard, which is like, our doctors are great, right? You've all seen these billboards, right? Sort of a kindly-looking physician, our doctors are great. On the other side, different health system, is an electronic billboard that says the current wait in our emergency room is 7 minutes, right? You're bleeding, where are you gonna go? You're in the 7-minute place, right? Because you think, and again, there's a general expectation that that quality is kind of good. Consumers believe that quality is good, generally, and they go to a better service place. Now, why do people believe that quality is good in American healthcare? They pay a lot for it. It's a luxury good, yeah, in the US. The issue, so it's probably because they don't know any different, right? Because it's hard for people to judge quality. Most people judge an operation based on the size of their incision, right? That's pretty how much they judge stuff. There's some fascinating things. So how could consumers find out about quality? So we're in New York City. New York is famous for having something really interesting in healthcare, which is for decades long, registry of cardiology and cardiac surgery, right? And what it'll tell you is the risk-adjusted outcomes of hospitals and individual cardiologists and cardiac surgeons. I will tell you what risk adjustment is if you don't know it. What risk adjustment says, risk-adjusted mortality says, I'm a doctor and I operate on people. I operate on really, really sick people, so you would expect me to have a pretty high mortality. Make sense? Versus, I'm a doctor, I operate on really healthy people, you'd expect me to have a really low mortality. Okay? So if you look me up and it says my mortality is 5%, if I'm a doctor who operates on really sick people, that's awesome. If I'm a doctor who operates on really healthy people, that's terrible. Okay? All with me on this? Okay. So, and for example, any Dr. Oz fans left in the country? Anyway, so Dr. Mehmet Oz actually operates here in New York City. You can actually look him up. Just look up the New York State Cardiac Surgery Registry. You can find out his data and figure out for yourself whether he's spending too much time on TV versus in the operating room. So, so back to issues of like understanding quality. So remember when Bill Clinton had heart surgery 2002, 2003 or so? Where did Bill Clinton go for his surgery? Anyone know?
Walter Reed.
Not Walter Reed. New York Presbyterian. Good hospital? Sure. What's your name?
Mark.
It's going to go downhill from here, Mark. What do you think, based upon publicly available data at the time that Bill Clinton needed to have heart surgery, what do you think the publicly available risk-adjusted mortality of New York Presbyterian was at the time? Just higher or lower than average?
I'll say higher.
You'll say you've been convinced to say higher because you're like, but a little higher, a lot higher?
A little.
What's a little to you, percentage-wise?
5%.
5% worse. Interestingly, at the time that Bill Clinton got his heart surgery at New York Presbyterian, the risk-adjusted mortality at New York Pres was actually twice as high as the average in New York and 11 times higher than the best performer in New York City. Now, Hillary may have known that at the time, but what's fascinating is that there was publicly available data about the quality of the outcomes here. And interestingly, 3 weeks after his heart surgery, he's back in the hospital with a complication. I'm not saying that those are related to their data, but it's kind of interesting. Now, that data has been around for a long time. Who uses it? Nobody. Nobody uses it. Interesting though, doctors actually use it. Doctors actually, when it's been shown over and over again, if you give doctors data like, here's the bell-shaped curve, here's you, they will actually act, right? They'll actually do something to actually try and bring themselves into compliance. The best example of this is actually around breast biopsies, where we went to general surgeons and said, here is the percent of your patients that you're doing breast biopsies on. So if you do breast biopsies on a very low percentage of your patients, what are you likely to do? You're going to miss stuff. If you do breast biopsies on everybody, what do? It's unnecessary, and not beyond unnecessary treatment, you don't wind up getting complications. So all you do is give them information. Are you like over biopsying, under biopsying, relative to the average? People sort of regress toward the mean. So the only people who've actually used this information have been the cardiologists and the cardiac surgeons to try and sort of figure out what's going on. Payers don't say to their networks, hey, if you go to these doctors based upon publicly available data, we'll pay 100% or 90%. If you go to these doctors, we'll pay 50%. If you go to these doctors, we won't pay anything because we don't believe it's in your best interest. They won't do that, right? Now, we are seeing development of narrow networks and other things, but at this point, people aren't real sure about that. And why aren't consumers sure about who their insurance company would send them to? So what's your name? Mitch. So Mitch says we send them to the cheapest. So essentially what the insurance care about is money. Not about me, about money. Right? So when we survey consumers about who they trust for health information, so on the top, people love doctors, love academic medical centers, love places like that. Actually like government agencies. They don't like the government very much, but they like the FDA, they like NIH. Go down a little bit more about getting health information. You get to places that are devoted to your disease. So if you have heart disease, people like the American Heart Association. If you have lung disease, like pulmonary folk, whatever it is, they like those folks. Get down a little bit lower, you get to the area of sort of groups that are associated with sort of patient information. So like Patients Like Me, as an example, is a place where people go and discuss stuff and have some more trust. And then you start getting down the Google area, right? And how many of you Googled some of your symptoms, right? Of course. Interesting, of course, Google flu was the thing that figured out, like, if enough people are Googling symptoms of flu, that the flu is coming back. They could actually predict the resurgence of flu before doctors and clinics figure out. Anyway, people don't trust Google that much. No one goes and says, "Oh, they walk into a doctor's office, based upon my Googling, I have hairy cell leukemia and therefore need this kind of treatment." People don't do that. What they do is say, "Look, I found this information," and they'll bring it to a trusted source and say, "Hey, does this apply to me? Is this something I need to think about? Is something relevant to me that I should think about?" That's Google. So who's at the bottom of the barrel? Let's talk about insurance companies, right? We don't trust insurance companies to give us health information, right? Because they're really not interested in our health, they're interested in our money and not spending their money. I'm paraphrasing. Who else do we not trust? No one. I mean, just about health information, right? So I know in the new administration we're supposed to go to those folks for our health information. So, but in terms of who you'd go for medical information, who else do you not trust? What's that? Insurance. So we've got insurance companies. There's three in the bottom of the barrel. They're sort of the three horsemen of the drug companies, right? All they just want to sell you more drugs, right? They want you to sit in the bathtub, be happy, right? That's all they want to do, right? So we got drug companies and we have insurance companies as least trusted. But there's a third one. There's a third head to this. Who don't you trust at all? Who doesn't care about you at all? Ralph. It's your employer, right? All they want you to do is work, and then die. Right? They're not interested. Yeah. That's right. Exactly. But you believe that, but literally, it's not true. It is not true. But you might come to believe, right, that they care about you. But ultimately, certainly if you're like, I'm not sure they really care that much about me. I think they're actually more interested in in sort of saving their own money and making sure I don't come to work when I get everyone else sick, even if I blow all my sick leave and everything else and I lose my job. They're much more interested in the bigger picture, right? So the sad part about this is that for consumers, most of the information that people get is from their employer, their insurance company, and the pharmaceutical industry. Right? So most of the healthcare messaging is coming from those three groups. So very problematic, right? So we least trust these folks, and yet they are the primary source of healthcare information that most of us get. Okay? We're not going to other sources, not getting other kind of data. We're sort of dealing with I don't really trust what's going on here. Okay? Big issue there. So we talked a bit about sharing information. One other aspect of sharing information is kind of tricky. I know you've had a lot of talk about security, and you mentioned PHI. Privacy is kind of funky in healthcare. Very, very funky in healthcare. How many of you are worried that someone's going to steal your identity and drain your bank account? Okay. How many of you are worried that someone's going to steal your identity and get a colonoscopy in your name? Less common concern. I always thought the person goes, I'm worried about that. I go, that's really problematic. What people are worried about is actually when you ask people to share information about healthcare, and some said this very eloquently, they're very willing to share information to help people, to help others who have this kind of problem. People are very, very generous with their information, except about that one thing, like that rash they got in Vegas, right? Some other kind of thing that happened that's in their medical record that they don't want to share. And the vast majority of Americans have something in their medical record they don't want to share. They're very happy to share lots of stuff, except this thing. Okay? So when we think about getting this kind of information, from moving this kind of stuff around, we have to keep that in mind, is that there's not everything that people want to share, and it's not related to every condition. So honestly, again, Somerset was an incredible story, and we have neighbors who have a young child who had a terrible tumor, and the outpouring of emotional support from the community was huge, and they're checking in at their visits and doing all that kind of stuff, and it was great. But for every family going through that, there is some guy going to an STD clinic with multi-drug resistant gonorrhea. That guy's not checking in on Facebook like going, hey, get another shot in my ass today, right? So there are aspects of healthcare. I go too far in that one? There we go, yeah. I got more, trust me. So, but again, we got to think about that. If that some of these solutions are going to be fantastic. They're going to be absolute game changers for certain aspects of healthcare. For other areas, impossible to change certain things unless we address some very, very particular issues on very granular control of data for individuals, to the point that if I went to my dad and said, hey, you can share information, but you've got to go through this whole list and say, I'll share this or I won't share that, or what circumstances, it's going to get too complicated for people and wind up opting out. And we're going to lose the power and you lose the generosity of individuals if we make it too hard for them. So how do we control that kind of stuff? So again, share, it's great to have this thought about information moving all around. You got to think there's some real barriers, economic barriers, there are privacy barriers, other kind of barriers that are important. The second area that we're not good at is around care coordination. Again, Summer brought this up beautifully. And I always bring up the issue of who's responsible right now for making sure that everything happens at the right place at the right time and things like that. Who does that? Yeah, it's exactly. So it's interesting. It's the classic thing when I did my oncology rotations, Mr. Jones, you have cancer. If you don't have a daughter, you should get one, right? Because someone's got to manage this stuff, right? And part of the problem is that most of our systems, again, we talked about why we don't share information. Most of our systems are designed to just either lock in data because that's all we had to do with it, or were really designed just to show what's the interaction between a provider and a patient at a certain setting. It's not a workflow across the hospital to the rehab place to the home health provider. It was never set up that way because no one really cared. I mean, as an example, I gave a talk about Medicare to my parents' retirement community. You want a tough crowd? That's a tough crowd. But I asked the question, who's had a hip replacement? And like, all the hands go up. I go, who's had 2 hip replacements? All the hands go up. I go, who's had 3 hip replacements? And again, loads and loads of hands go up, right? And the reason being is that if you had, and my mom's had hip and knee and all sorts of replacements, if you had a hip replacement, the doctors got paid for doing a good job on your hip replacement and getting you out of the hospital in a timely fashion. That's how they were judged. They weren't judged on how well you did. They weren't judged on 6 months, 12 months later how well you're walking around or whether you have pain or not. Because they knew that if someone had one of those problems, they could just come back and put another hip in. Right? My mom's like an annuity for the orthopedic surgery practice. But now, as you talked about readmissions and other things, it's being judged on outcomes, on quality, in this sort of a more value-based care world. Something they care. They care what happens. They care that, for example, are they getting proper physical therapy when they leave? When they go to the rehab place, are they doing the right stuff? They want data back and forth because they're ultimately going to get paid on how well someone does. And if it's based on what happens there, they're going to do it. Similarly, we talked about some of these remote monitoring and sort of even the activity monitors. Like if my mom's hip is dependent on her walking 5 minutes and then 10 minutes, whatever, every day, you can bet the surgeon would put would put a Fitbit on her, would introduce her to other people, right? Would get her on Ralph's leaderboard, right? To get them all exercising together, because that would make great sense. Right now they don't do it because A, there's no reason to, and B, it costs them money. They're never going to recoup. Until we start getting more penetration of value-based care, suddenly all that stuff makes sense. They'll give them apps to take a picture of their wound to make sure the wound's not getting infected. They'll give them all sorts of coaching. Right? They'll do a lot of stuff, but right now it doesn't make sense. So unless they're really pushing toward value, they're not going to do that. They don't really care about care coordination until suddenly they have to. Right? And that's where I'm going to start seeing some elimination there. The big area I want to talk about is consumerism. And again, I keep drilling on consumers because, again, how consumers operate is very, very different from how healthcare thinks of consumers operating, how they judge stuff and other things. And what's interesting now is some of the endpoints that we're looking at in value-based care are things that are actually important to people, right? It's not what's important to healthcare, it's important to people. Like, can you walk around? Can you play tennis? Can you do other stuff? Can you do regular activities? Things that are important to people. Are you happy? Right? You never thought about asking those kind of questions before. Like after surgery, how do you feel? Do you feel better for having done this? Those kind of outcomes. And it's not the kind of thing that, that providers at life sciences companies, a lot of folks ever really thought of having to deal with and taking that information in. Now we have a lot of really interesting ways of collecting that information. And we see remote monitoring, all these devices. Devices are great, but there are a couple problems. First one is that, how many of you have some sort of like body monitoring kind of thing? Who's got what do you have? Just a watch? What do you have? Apple Watch. Lots of Apple Watch. Who's got something cool?
Like a scale, right? Blood pressure cuff.
Oh, you got a lot of cool stuff. So I got everything, right? As Carrie probably explained. So I got the activity monitor, I got the heart rate monitor, I got the rectal probe, everything going, right? Our heart rate monitor broke. But anyway, there's a lot of information I can get. But as Summer said, does my doctor want that information? No. What could they do with it? What could they possibly do with this flood of information coming into them, right? All of us in our family are bike, right? I can tell you what my heart rate was based upon my GPS coordinates. Does that doctor want to see that? No, right? What we need, though, is to be able to identify this data that we have that we're collecting is something different, has something changed, right? And so, if there's something I need to act on, can I get some information about that and think differently about what's happening so we can take advantage of this stuff in a way that'd be meaningful. Now, the other problem we have is that everyone who raised their hand who has some cool stuff, again, looks pretty healthy to me, right? And when you think about, we have all these devices designed for this. I'm going to do another slide here. It's like next slide. Really healthy people here, and really sick people down here, right? So most of these devices are targeted toward really healthy people, athletes who want to, or people who are fit, who are trying to get fitter. Even though the people down here are the ones who really, really need it, right? They could really benefit from it. So why, right? For the vast majority of these folks is that the reason they stay in the fitness and wellness space is to avoid regulation. And in Carrie's panel, I talked about the different types of devices and the sort of protocols. Most of the really innovative companies doing stuff in the sort of the monitoring area, they don't have compliance attorneys. They're not used to dealing with the FDA. And their investors are going, hey, if you start getting yourself at risk for regulation, that's really tricky. So they sort of stay down here. And so it's not until we begin sort of push things more and more from wellness and fitness into actual health that we're really going to recoup some stuff. Because right now, they can sell these devices for $50 or they can sell an app for whatever, right? Versus up here, you've got billions of dollars, right, of healthcare spend that could be impacted by it. And that's going to be the real transition. The other problem is you don't even know if this stuff works, right? So I have a lot of devices. I've got just because I have a fitness app on my phone, it doesn't make me an athlete, right? And just because I have a diabetes app on my phone, it doesn't make my hemoglobin A1C go down. So we have to see is that it's really data that this stuff really even works, even valid. There was a company that I saw that had a device to measure stress, and it would look at your GPS coordinates and say, hey, you're most stressful around here, or you're stressful somewhere else there, you should do less of this and that. And I said, well, how does it monitor stress? He goes, well, we have a little thing. I'm going, and it measures like your skin something or other. I go, that's interesting. Because when I was in 6th grade, I had a mood ring that did literally the exact same thing. It told me that I was in love with Mary Thurber, actually, at the time. But nostalgic. But do these things actually do what they're supposed to do? Because again, they're living in this space almost like sort of the nutraceutical kind of garlic pill world, right? They can make any kind of claim they want because they're not really considered medical device or part of the medical establishment. And I think one of the reasons that the medical establishment has been very reluctant to adopt a lot of these things is because there's really not a lot of evidence that actually do what they're supposed to do. As cool and awesome as these things are, it's really sort of an untapped thing of potential. So the other part is, again, thinking about consumers, is that we've been thinking that if we give consumers more financial responsibility for their health, they'll make better decisions, right? Has that worked for any of you? I don't see any hands flying up on this one. One of the things that we've done is we've given people more financial responsibility. We've given them high deductible plans. We've given them larger copays, other things like that. But we haven't given them any information about actually how to make better decisions. Haven't given a way to make better decisions. Only the responsibility for doing that. And so what we do, instead of having people make better decisions about their health care, what most of them say is like, hey, now I know health care is expensive because I'm paying more for it. So what do I do if I go to a doctor, say I need a knee arthroscopy, and the doctor says it's going to be $2,000. What do I do?
Go without.
I skip it, right? As we're seeing over and over again, people don't go and say, you know what, I'm going to find another doctor who charges less, right, and has high quality. They don't do that, right? I mean, all of us, I assume many of you are going out to dinner tonight. You can pick up the Zagat's Guide, and you can find a place that will tell you, or even Yelp, right? A high quality place that is the price point that you want, that has the ambiance, whatever you need. You can find that place, right? You can't find a high quality physician, right, that charges less than someone else. Can't do it. Right? And part of the problem is because what's available to consumers actually doesn't make a lot of sense to consumers. How many top 100 hospitals are there in the United States? Anyone want to hazard a guess to this one? So there are actually about 720 or so top 100 hospitals. And here's the problem, is that there are there are a number of organizations that talk about this. So you have U.S. News and World Report, you got Consumer Reports, you got Health Grades. I'm blanking on the fourth one. Anyway, so there are these organizations that do this. How often do you think that a hospital that's on the U.S. News and World Report top 100 hospitals is on the Consumer Reports top 100 hospitals? What do you think the overlap is? 5%. It's about 10%, a little better, right? So about 10%. So it's only 10% of the time they appear on two lists. Forget about the other ones, right? What's really troubling is that for many of the hospitals that appear on the top 100 on one list of awesome, they're on the naughty list of the other place. And so how do you reconcile that? Like, oh, they're the best place to go generally, or they're terrible for this? Right? How do you make that kind of evaluation? The kind of information consumers have actually is kind of twisted because what they're looking for is quite different. And a lot is very personal. Some are talking about having sort of the patient at the center. People make different decisions. So Luca, our middle son, who's leading our youngest son on the bus tour right now, Luca had a wart on his foot a couple years ago. Now, I could have taken him back to Hopkins, where there's a world-famous virologist I could have taken him to look at his foot. Or I could have taken him to thewartguy.com, who works in Bethesda. Where did I go? I love my kids. Where did I go? Of course I went to the Wart Guy, right? Do you think I'm going to drive all the way to Baltimore and wait 4 hours to see some guy, right? Forget it. We showed up at this place at 4. We had an appointment for 4:30. At 4:25, we're back in the exam room. At 4:40, we're out the door with most of his foot intact, and we were delighted, right? Right? Now, if he had something more serious, I probably would have gone somewhere else, right? But at the time, what I really wanted was convenience. To me, my own personal story, about a year ago, and Carrie can attest to this, I woke up in the middle of the night with incredible pain in my right upper quadrant. And as a doctor, of course, I immediately knew I had cancer. So after, saying goodbye to Carrie and the kids, I wound up actually realizing, of course, it's my gallbladder. And I went to a local community hospital, which I know is a great place, and I got a good friend who's a general surgeon who works there, and I get all my stuff done in one. So I went to the emergency room there and spent most of the day there. And went through, and of course, all the gallbladder tests were negative. And then it was, well, because I had this terrible pain radiating to my back, blah, blah, blah. And they go, well, Harry, you fly all the time. You had a sudden onset of pain that was radiating to your back, and you were even short of breath. Maybe you had a pulmonary embolism or some other cardiac event. I don't want to have a cardiac event. Because if I'm having a cardiac event, I'm in the wrong hospital, right? And it's not like I could, sort of cover my ass in my gown and walk out of there and go to a different hospital where my cardiac surgery friends were, my cardiology friends. I had made a decision. And for most consumers, the first decision they make about what to do or where to go is what ultimately determines their outcome and the total cost. So if you've got neck pain and you said, I'm going to go see a neurosurgeon, I'm going to go see an orthopedic surgeon, I'm going to go see a neurologist, I'm going to go see a chiropractor, I'm going to go see a massage therapist, whatever it is, whatever that first decision you make is ultimately going to determine your outcome. So I had wound up in the gallbladder hospital with a potential cardiac problem. And of course, Carrie was right, there was nothing wrong with me. And I don't know, $1,000 in copays later, I'm fine. Lost that bet. But anyway, but again, so consumers, when they make a decision, for whatever reason, it's often based upon an inadequate access to information, and they'll go somewhere, but then they'll learn something which they actually can't even act on. So unlike lots of other different things that we have, it's not like if you show up at a hotel in New York and the hotel is terrible, you can't just walk down the street to another hotel room. You can't do it in healthcare. You can't say, I can make an objective decision. This is bad. I'm going to go somewhere better, and someone else will appreciate my business. Don't have that in healthcare. So again, this consumer piece is a very challenging piece. The last piece is around analytics. So we're really bad with data, and data flow is awesome. We think data is very cool. We use some. We talked about earlier some interesting information. The problem we have in healthcare is the data that we need is not the data we have. So when you look at the determinants of your health, only about 10% of your health is determined by the care you receive, right? About 70% of it is where you live and your lifestyle choices. Like what you do and where you live. 70% of your health is determined by that. And as I think even Kerry mentioned, like if all of you know where you ate, what you did. Your credit card knows that. Your phone knows that. Healthcare doesn't have that stuff. Healthcare doesn't have these kind of predictors of what's going on with you. We have this weird data of these very skewed pictures of when you showed up for care, what was going on with you. How many of you floss crazily before you go see the dentist? Yeah. It doesn't necessarily, like when the dentist finally sees you, it doesn't necessarily reflect, what's going on with you. It reflects some odd moment. We don't have that kind of data. Now, for example, if the dentist were able to look back through your Amazon or your supermarket purchase and said, look, you haven't bought dental floss in a year, but you bought it 5 days before you showed up at the dentist, right? Do you know why eHarmony and Match.com kind of work? They don't judge you based upon what you say. They judge you based upon what you do. So Kerry, you don't have to listen to this for a second. If I theoretically had put a profile, this is going to go bad really fast. But if I put a profile up that says, I like long walks on the beach, because people are supposed to like that if we're romantic, and I love going to the opera, because it sounds classy, right? If you look through my Visa bills for the last 30 years, you will never see the purchase of a single pair of opera tickets, right? And so I may portray myself as something, but all this data gives that away. I may say I'm healthy, but if you look at our grocery store stuff, you can see, am I buying kale? Am I buying frozen waffles? Right? What am I doing? Right? So all this kind of data is going to be very, very predictive. And also, as Summer mentioned as well, there's a lot of other data that's really important. So for example, if you shop at Home Depot and suddenly stop shopping at Home Depot, your risk of depression has just gone way up. Right? You suddenly don't care about stuff. Similarly, in a very personal one to me, if you buy dog food and then you stop buying dog food, what happened? Dog died. Right? Again, there are these sort of triggers that you can pick up from your consumer behavior that marketers and other people have great access to that we don't have access to. And a fascinating one in the telecom industry was an interesting pilot in the VA about suicide prevention, showing that as people became more depressed, the ratio of how much talking versus texting people do as they get more depressed begins to change. You do less talking. You do less of everything, but you do less talking and relatively more texting because you don't want to have direct interaction with people. You don't want to talk to them, but you're willing to have some interaction. Interesting also is the geodynamics of what you do shrinks. So right now, you go to the movie theaters, you go out to dinner, you go to shopping mall, you do a lot of stuff. You're bouncing all over. So if you look at the map of your phone, it's all over the map, right? As you get more depressed, it starts to shrink and shrink and shrink. So you get these sort of pieces of data together, you can make a lot more sense out of it. So a lot of interesting stuff that we're going to have to do as we sort of move into the future. I think the last thing that I think what's really important is that we have spent a lot of time in healthcare developing leaders in a way that has met sort of our fee-for-service kind of world. We've spent a lot of time developing kind of race car drivers. People who are really good at getting a whole team around doing the same thing over and over and over again. And what we're finding now in a value-based world, what we really need, we don't need race car drivers, we need airline pilots. Right? We need people who are much more flexible. They're worried about safety, they're worried about quality, they're worried about customer service. They're going to go where people want to be. And it's a different profile of individual because right now in the fee-for-service world, the people who are leading these organizations, the ones that you're going to interact with in healthcare, their whole MO has been around trust in the system, improving the system, right, to be more effective and more efficient. Some have gone the route of being more consumer friendly, other ones have been more kind of more quality focused. But as they try to move to value, it's really about being much more reactive, much more agile, much more able to understand what's going on and move with the market, understand what's going on. It's a very different type of skill set. So that's going to be a big challenge, working those kind of things together. With that, I think we have a couple questions here. Let me see. Okay. One is one interesting is what is your take on the quantified self movement? I think one of the interesting things, again, is that we wind up in a situation where people are collecting a lot of data about themselves, often whether they need to or not. Right? There are big groups of people, again, going in the fitness world, who have tremendous data about themselves. What we really need to understand is what's going on to people who really need it. The flip side of that is, do we actually need quantified self data on people to be effective? So, Kerry mentioned my dad and his whole health stuff, but I could put a 24-hour heart rate monitor on my dad and have some call center monitoring it 24/7 and to see how he's doing. Or maybe I could put a little sensor on the refrigerator in my parents' apartment. And if no one's opened the refrigerator by 9 o'clock in the morning, maybe I give them a call saying, hey, you feeling okay today? Right? So do we actually need to get this really deep and rich physiologic data about people to understand what's going on? Or are we better off with other types of indicators? Are we better off, again, looking at, are they getting food? Are they getting other kind of stuff? Are they paying their bills? Right? Do they have heat? Do they have electricity? Do they have other things? Is that data going to be important? So, I guess, most broadly, is that if we think about the future of healthcare, we got to think a couple things. Is that, again, a lot's going to change on how we pay for healthcare, but a lot's going to depend on how we view healthcare, of what are we really trying to do? What's our incentive? Are we trying to improve health? Are we trying to do some business thing? Are we trying to do something else? And do we really understand the people who are involved and their motivations and their desires? Because the reason we think people are doing things is not necessarily why they're doing that stuff. Anyway, with that, we're out of time. It's been a great conference. If you have questions, I'll be around for a bit. And thank you again for having me.